Okay, so yesterday we talked about oral ulcers and pre-malignant lesions of oral cavity. Maybe some of you already know about the oral ulcers from the previous lectures. So it's a revision, and then pre-malignant lesions are different from pre-malignant conditions of oral cavity. And then finally, there are the tumors or the malignant conditions or lesions of the oral cavity. So we'll just focus on the pre-malignant lesions, not the conditions which lead to malignancy or tumor in the future. So ulcers and lesions are closely related. That's why I gathered them in a single presentation. So oral ulcers, as we know already that from previous lecture yesterday, we studied that there are two types of oral ulcers. There was multiple oral ulcers and recurrent oral ulcers. So oral ulcers are generally classified as multiple oral ulcers and recurrent oral ulcers. And then there were, among the multiple, we have acute presentation and chronic presentation of the ulcers. And then on the right side, we have causes of mouth ulcers, which were acidic food, lime, pineapple, strawberry, more citrus fruit, viral and fungal infection, you know some of them, and then dental braces, mouth wounds, lack of vitamins, especially B12, folate, and iron. And then we had started with acute multiple ulcers, and the causes or causative agents included primary herpes simplex virus, herpes angina, Coxsackie, hand, foot, mouth disease, chickenpox, herpes zoster shingles, and erythema multiforme. And on the right side, we had an approach to diagnosis of a single episode, how a single episode of ulcer occurs, either it is due to trauma, drugs, or iatrogenic due to caused by doctor's malpractice or any circumstance during the treatment of the patient. And then we have infectious cause. Among infectious, we had viral and bacterial. And in viral, we have these: herpes simplex virus, zoster virus, Coxsackie with hand, foot, mouth disease, herpes angina, A, rubella, and Epstein-Barr virus. And then we know that what are the diseases caused by these viruses. And bacteria, we had ENUG, syphilis, gonorrhea, tuberculosis, schwannosis, and stroma. All of these have some manifestation in causing oral ulcers. Oral ulcers, excuse me. Yes, oral ulcers acutely. So now we go to the next slide. Okay, after that we started with primary herpes simplex. What was there? There was after 6 months and peaks within 2 to 3 years. And then prodrome was there, which was 1 to 2 days before the appearance of local lesions. There is ulcers, and before these ulcers, appearance of these ulcers, there was a prodromal area, prodromal periods, where there are flu-like symptoms, including fever, headache, lymphadenopathy, malaise, vomiting. Some of these are here. And then we had acute marginal gingivitis, also known as primary gingivostomatitis, because of HSV. These vesicles are multiple and turn to painful bilateral ulcers surrounded by erythematous halo. As you remember, they were had yellow in center and they were surrounded by red halo, erythematous halo. And you can see the mucus is ruptured, the epithelium is ruptured, keratinized, and then ulcers are deep here. And these are mainly in keratinized gingiva and mainly at the anterior area of oral cavity. So this is anterior area of oral cavity, have marginal gingivitis, improves the margin of the gingiva, and then prodrome is 1 to 2 days before. Okay. Next was herpes angina due to Coxsackie virus A4, which affects the children of from 3 to 10 years. Clinical pictures, it also has prodrome, but the prodrome of herpes angina Coxsackie type 4 causing herpes angina is milder than herpes simplex. There is sore throat dysphagia, ulcers mainly at the posterior area. So in herpes simplex virus, the area involved was anterior area. And this here, the posterior area of the oral cavity is involved, which includes soft palate, uvula, fauces, tonsils, and posterior pharynx. So what are these? Soft palate and uvula, fauces, tonsils, and posterior pharynx. Ulcers are smaller than herpes. So herpes simplex virus in comparison to herpes angina, very good and favorite question of examiners. That prodrome is milder than the herpes and ulcers are smaller, but herpes are more painful. But sorry, herpes angina is more painful. Is angina is pain. Herpes angina is more painful. And there is no marginal gingivitis here in herpes angina, and it's mainly in the epidemic areas. These are two main important, one of the differences distinguished from all the other viral diseases causing oral manifestation and oral ulcers. So these are important things. And then we discussed hand, foot, mouth disease, which was by A16 Coxsackie A virus, type A16, and it had low-grade fever. Excuse me, low-grade fever. There was oral vesicles and ulcers more extensive than herpes. So the extension was there. It was present oral perilabialis, and then on extensor surface of hand and feet, and then also on the flexor surface of hand and feet, right? Around periorbital. Okay, perioral. Then we had low-grade fever, oral ulcers, extensive macules and papules on the extensive surface of hand and feet. That's why known as hand, foot, and mouth disease. And then if there is acute stomatitis and fever, then you need to examine the hands and feet to confirm it is hand, foot, and mouth disease. Okay, so this is a revision. We are going slowly. And then we said chicken pox. Chicken gives eggs so that their ulcer are very shallow and yellow. How to study this? Primary infection of varicella zoster virus, chickenpox, cutaneous lesions, and oral lesions. The cutaneous lesions were maculopapular lesions, and oral lesions were sores in your mouth. However, do not look like chickenpox blisters like on your body. They are different, as the appearance of chickenpox sores or lesions on the body and mouth are different. These sores look like raised bumps. You see this? It looks like a raised bump that lasts about a day. After that, these bumps or sores or lesions are transformed into ulcers, which are shallow and yellow or gray in color, and they also don't crust over like as the lesions of the body. They do not crust over. Okay. And then next we had a second manifestation of vis-a-vis varicella zoster virus, which was oral shingles. And we said in oral shingles, clinical picture was the prodrome was also 2 to 4 days with shooting pain, paresthesia, burning sensation along the course of the nerve. So here we said along the course of the nerve was important. And the lesions, what about the lesions? They were unilateral, very important, unilateral. You see here, half of the mouth is affected and the other half is still normal. Half of the roof of the floor is normal and half is affected. So it is unilateral lesion. So unilateral vesicles on the erythematous base appears as clusters, groups along the course of the nerve. So also along the course of the nerve, shingle, oral shingles or shingles along the course of the nerve. The most diagnostic manifestation, a hallmark of this disease is unilateral appearance of lesions. The typical symptoms of oral shingles include a tingling or burning sensation. Remember here, we had paresthesia, tingling and burning sensation. In the mouth, because we are talking about oral shingles, facial tenderness and tooth or mouth pain can be there because of the lesion can cause a surrounding pain. Okay, perfect. So now we go to the last part of the viral infections. or last part of the ulcers caused by them. This is actually not, there is no prodrome here. This is different, that it does not have a prodrome here, and affects children and young aged, rare after 50 years, rare after the age of 50 years. Okay. Clinical pictures, there is no prodrome. This is one of the 6 diseases in acute, which is acutely present, acute multiple ulcers, but there is no prodrome. Because, so what is different in here? There is no prodrome, but there is systemic and local lesions appear together with a very rapid onset. Of course, it should be rapid onset because it is acute. What about the lesions of erythema multiforme? What about the lesions in the oral cavity? Bulla or vesicles on an erythematous base, then they rupture and release the fluid, exudate. Lesions orally are anywhere, but lips are more prominent. So we said that erythema multiforme had a special place, which were lips. So lips are more prominent in such case. So lips were more prominent. Where lips are extensively eroded and a large portion is denuded of epithelium. Here you can see a multiforme. All of these pictures on the right side, they focus on the lips, right? They focus on lips. So that's why I used a lot of lips so that you can remember erythema multiforme, how they cause acute multiple ulcers. Rarely gingival is involved. So we don't want to learn rare things. If it's involved, but it is most diagnostic. So after the lips, gingiva are involved, then it will become the most diagnostic for erythema multiforme. And what was another who was involving gingiva? It was involving the acute marginal gingivitis. It was HSV, herpes simplex, the first one and the last one. What about the lesions? There were bulla and vesicles which rupture. You understand? The lesions are large, irregular, deep, and often bleed. Because they are deep, they reach to the local vessels and bleed. And there are tissue remnants attached to it. So there is almost a crusting of lips due to dryness. Okay, this was all the acute multiple oral ulcers. Now, what about chronic multiple ulcers? So here we will just study 2 of them, which are pemphigus vulgaris and mucous membrane pemphigoid. Yesterday we already studied, so now we go again to them. Oral lesions of pemphigus vulgaris usually present 4 months before cutaneous lesions. So before the pemphigus vulgaris have a manifestation on your skin, on the patient's skin, 4 months before it will have an oral manifestation where it cause oral lesions. So how would their lesions look like? It is in atelized form, classical bulla on uninflamed area, then rapidly breaks, leaving irregular erosion. So irregular erosion will be there that extends peripherally. From the center, they extend peripherally. Leaves denuded, eroded area, deep irregular area, ulcer, mainly at the buccal mucosa, where how to differentiate PV from EM and HSV, VSV. First of all, pemphigus vulgaris is at the buccal mucosa, whereas erythema multiforme or erythema multiforme is mainly on the lips. We just studied this, right? Other than that, because it has a chronic appearance, chronic clinical picture, it will take time. That's why PV or pemphigus vulgaris is different from herpes simplex virus causing oral ulcers, varicella zoster virus causing oral ulcers, and erythema multiforme causing lips or oral ulcers, because it has chronic appearance. Which has a chronic appearance? Chronic multiple ulcers, pemphigus vulgaris. In the chronic multiple ulcers, the other one was mucous membrane pemphigoid. It was involving mucous membrane. Okay, let's see about it. Age over 50 years old. For mucous membrane pemphigoid, the age should be over 50 years old, mainly mucosal surface involved of the oral cavity. That's why mucous membrane. Clinical manifestation, clinical picture was desquamative gingivitis. Desquamative gingivitis. Desquamation will occur. What is that? Squamous cell epithelium will fall off while there is inflammation of gingiva. Then how their lesions look like? How does their lesions look like? Let's see. Vesicles that rupture, leaving erosions that spread peripherally more slowly and self-limited. So it is more slowly than PV, pemphigus vulgaris, and it is self-limited than pemphigus. That's important part because both are chronic, but this one is slow and self-limited. Then the other chronic multiple ulcers, which was because of pemphigus vulgaris, PV. This is MMP. Okay, so there is a sign for this positive Nikolsky sign. Nikolsky sign is a skin finding in which the top layers of skin slip away from the lower layers when rubbed. So what happens is if you have cutaneous lesion or any lesion here, if you press your finger against it, the top layers will be removed easily and the lower layers will be there and it will give more underlying erythematous appearance. There is no cutaneous involvement. There is no cutaneous involvement. So if there are chronic multiple ulcers, if there are ulcers here and after 4 months there is cutaneous lesions, then it must be pemphigus vulgaris because mucous membrane pemphigoid has no cutaneous involvement, unlike pemphigus vulgaris. The other differentiation factor was both were chronic, but mucous membrane pemphigoid was more slow to progress or spread peripherally, and it also was self-limited. So after 4 months, there are no cutaneous involvement because its self-limited has healed, the body has developed the proper immune system against it, and there will be no cutaneous involvement in the future. And this was another differentiation where we were just focused on pemphigus vulgaris and mucous membrane pemphigoid, which were these two. Okay, so now to the third part, last part of oral ulcers, which was recurrent oral ulcers. Recurrent oral ulcers include recurrent aphthous stomatitis, RAS, also known as aphthous ulcers, Behçet's disease, and then recurrent herpes simplex caused by the herpes simplex virus, the recurrence. The first was aphthous ulcer. So you see aphthous ulcer on the left side, cause or etiology not well understood. So there is one theory which tells about it that it must be cell-mediated immunity, where it leads to increase of T cells, especially T helper 1 cells, chemokines, and macrophages, where they release these chemokines, release interferon gamma, include interferon gamma and tumor necrosis factor alpha, and it all occurs in the oral mucosa. That's why aphthous ulcer are studied under oral ulcers, and because it caused the recurrence again and again, that's why they are studied under recurrent aphthous ulcers. On the right side, we have background. Can we just, okay. On the right side, we have background, where they say these aphthous ulcers are also known as canker sores, not cold sores, canker sores. These are canker sores. They are small, they are painful ulcers, form on non-keratinized oral mucosa, except the major one. Minor is formed on the non-keratinized oral mucosa, where it is found in the inner lips, cheeks, soft palate, floor of the mouth, gingiva, and tongue. So suddenly a patient has an abnormal ulcer on lips or cheeks or oral cavity, and he does not know and you cannot get a clinical picture or fever or prodrome or any related symptoms or signs, then they can be aphthous ulcer. When there is an absence of a clinical picture, there is absence of a prodrome or prodromal symptoms, then you can say it can be as aphthous ulcer. And how to confirm? You go for the causes: weakened immune system, certain foods, stress, nutritional deficiency. For example, the patient says, I'm a vegetarian. Nutritional deficiency. There, the vegetarians have a lot of vitamin deficiencies, especially vitamin B12. And suppose the patient says, okay, doctor, I have noticed that whenever I eat seafoods, I get some ulcer in my mouth. Or whenever I chew some tobacco or I smoke, sometimes I develop some ulcers which are limited, and after a few days or weeks or 1 week or 10 days, they go. But sometimes one of the ulcer gets bigger and becomes a major aphthous ulcer, major aphthous, and it burns a lot. So actually, I'm not worried about minor ulcers because I cannot quit smoking, but I am worried about the major ones which become big, which are bigger and they cause burning. So can you help me? We'll say, yes, you need to manage your smoking. But doctor, I cannot quit. Okay. So we give you the treatment and you have the choice. But we suggest you to do that. So we suggest you to manage stress because of the increased stress, it also occurs. And we suggest you to have a healthy diet, good oral hygiene. That would be perfect. So what are the signs, symptoms of aphthous ulcer? As you remember, they are pinpoint papules which gradually expand and become bigger. They are well circumscribed, means they are absolutely round. With a central yellow. Okay. And then we have some pinpoint markings, redness, which shows some active lesions. Okay. So we have some pinpoint bleeding spots. Okay. So these include pinpoint papule extended, which gradually expand. They are well circumscribed, means they are round. They are round, oval, yellow-gray, pseudomembranous center, inflammatory red halo. Heals within 7 to 14 days. Ordinarily, minor aphthous ulcer, which are small, they heal in 7 to 14 days. Okay, let's go to the next slide. So here we have recurrent aphthous ulcers. Recurrent aphthous stomatitis mostly begins during the second decade, the age of 11 to 20. Prodrome. There is a prodromal area from 2 to 48 hours before an ulcer appears and causes a burning sensation. Localized erythema, localized redness, then small white papule will appear, and finally it will ulcerate. When will it ulcerate? When the yellowish membrane, this yellowish membrane will remove, it will become an ulcer. What is an ulcer? A deep lesion of the skin involving the lower layers or mucous membrane, a deep lesion of skin or mucous membrane, excuse me. Then it is not preceded by vesicles. Not preceded by vesicles because it will not contain any fluid. They are uniform, looks uniform enough for me, well circumscribed, round, painful, covered by a yellowish membrane and surrounded by an edematous halo about 10 millimeter or 1 centimeter. We are talking about the minor ones. No tissue remnants on the borders. The border looks continuous with the surrounding tissue. So the border cannot be distinguished from the surrounding tissue except the area of yellow area, except the aphthous area, aphthous ulcer area, and the surrounding reddish margin or the edematous halo. We cannot distinguish the edematous halo have a distinguished border between itself and the surrounding tissue. So there are no tissue remnants on the borders, as there are also no vesicles. If the vesicles are there, if it's fluid filled, then the exudate, whenever the exudate will come out, the superficial layer will get crusted or it will dry, and the tissue remnants will be there. The remains of the tissue, dried out tissue, will be there. Mainly on lining mucosa, rare over keratinized mucosa. So this is talking about the minor aphthous ulcer, which is rarely on keratinized mucosa, rarely. So where it is mainly on the lining mucosa. Okay, so let's go to the next slide where it shows major aphthous appears also on the keratinized and non-keratinized mucosa, and it is bigger than 1 centimeter, usually 2 to 3 centimeter, but not limited to 2 to 3 because it can be up to 5 centimeter in diameter if we did not take care of it. How the lesion looks like? What does the lesion look like? It's indurated base, everted edges, very painful, and leaves a scar. So indurated and everted edges of the ulcer is rough, is big, is painful, is very painful, and on healing, it does not completely heal. There will be a fibrous tissue remains that is known as scar. Takes more than a month to heal, unlike minor aphthous ulcers, which take 7 to 14 days. These takes up to a month to heal. We are talking about major aphthous ulcer. Perfect. Okay, the last one is herpetiform ulcers, which are the least common. These are least common, but they are pinpoint, and dozens and hundred are there together, forming and surrounded by an edematous halo. They are very pinpoint, 1 to 2 millimeters, small in size. Okay, forms of aphthous ulcer, then revise, then we have a overview. So as we know, we have the aphthous ulcer, mildly painful, annoying, a few millimeters across, usually 1 centimeter, and heal 7 to 10 days, no scarring, and reoccur. If there is recurrence, usually 3 to 4 times a year. But if it is reoccurring more than 3 to 4 times a year, then it is recurrent aphthous ulcer. Recurrent aphthous ulcer, more than 3 to 4 times a year, which can at the most or at the extreme may occur monthly or multiple times in a month, and the range of the age is from childhood to age 40. And now from the minor side, how the major distinguish is they are more than 1 centimeter, more painful, more frequently occurring, and they heal, self-heal into 10 to 30 days. Mostly this part mostly take a month, and they do not completely heal because they will leave a fibrous tissue known as scar. And then we had finally a herpetiform ulcer, usually in the females, not linked to herpes. Do not confuse from the herpes, the name. They are tiny, discrete, and then they get together, coalesce, get together to make patches known as ulcerated patches. Herpetiform ulcers get together to make ulcerated patches. Heal almost as same as minor ones, 10 days, and they can also reoccur frequently. Perfect. And then this was difference between aphthous ulcer and HSV, herpetiform, or sorry, herpetic ulcers. And then this was the different we already discussed yesterday. And then there was a difference between a detailed difference between herpes stomatitis. Here is on the left side and here is on the right side, and then aphthous stomatitis. Why they are being distinguished and compared and contrast? Because their name and their appearance looks very the sore, but these are cold sores and these are canker sores. Okay, perfect. So the causes for herpes stomatitis was herpes simplex type 1, causing primary gingival stomatitis. And then for aphthous stomatitis, the cause was unknown, but mainly because of poor oral hygiene, damage to mucous membrane, local infection, food, systemic diseases, or any allergic reactions, or physical or chemical irritants, smoking, tobacco, nicotine gums, sometimes nuts, bitter nuts, tobacco chewing, all these. And then on background, we had inflammation and redness of oral mucosa. It affects the inner cheek, gums, and inner lips. Both have same background and causes painful mouth ulcers and white lesions. Diagnosis based on medical history, clinical picture, physical examination, bacterial viral culture, because viral culture will give us herpes stomatitis confirmation because it is due to herpes simplex virus. So viral cytology viral culture can help us, and laboratory tests, for example, biopsy, scraping, they can help us to distinguish. Finally, the treatment, if it is virus, antiviral, and if it hurts, it pains, it burns, tingles, tingling sensation, burning sensation, topical ointment. Oral mouth washers, oral rinses, you can do goggles, chlorhexidine, anti-inflammatory meds, and then chemical cauterization by electrocauterizing device can also be done. Then the second one was Behçet's disease. I think from till yesterday we have done it here. This was absolutely important topic. That's why it has been revised, because these are the ulcers you're gonna, even if you are not in as a dental physician, you can have an occurrence of with a patient will present to your clinic with some ulcers where you can relate. So you should remember these ulcers. So we have some few minutes before we go to break. So where we can ask, or you just say 37 people, we just disturb some people. Let's disturb some people. Okay. Roll number 31, Mustafa.
Yes, sir.
Any question regarding today's topic?
Clear, sir.
Okay, perfect. Abbas, roll number 36.
Yes, sir.
What are the two chronic multiple ulcers you know about? Any two
Sir,
chronic multiple ulcers?
Figus vulgaris and mucomembranous meningitis.
Can you tell us without looking any difference between these two?
Sir, Pimpenka vulgaris, sir, it will extend peripherally, sir, and other one not, sir.
Other one mean mucous membrane pemphigoid will not
yes,
spread, will spread,
sir.
it will spread. It will also spread. It
Yes,
will,
sir.
both of them will spread peripherally. Both of them will.
Yes, sir.
You said a little wrong. Both of them will, but one is more slower. Which one is more